So I'll be talking on two topics, DALK and DMEK. So DALK is the anterior lamellar keratoplasty, where the first four layers are transplanted, and DMEK is exactly opposite. So the fifth layer is transplanted. So these two surgeries are very successful surgeries. I'll share my experience and tips. So the indications for any lamellar surgery is any disease which involves the corneal stroma in the presence of healthy endothelium. So nowadays, it is, as we say as corneal surgeons, we say as more as corneal layered, because layered corneal surgery is the future, where any layer has a problem, you replace that particular layer, you don't replace the entire cornea, and this gives very excellent results. For any anterior stroma, for example, corneal ectasias like PMD and keratoconus and keratoglobus, and any corneal scars, partial thickness scars, corneal stromal dystrophies. For scars, you have OCTs nowadays. You measure exactly the OCT, what depth, 200, 300, whatever, and you can exactly cut that portion and replace that portion. So any anterolamellar, this is for any superficial scars. For example, if you measure 200 microns or 300 microns, you can use a guarded blade. This comes around 250, 300, 350. You make a 360-degree depth along with that, all 360 degrees, and then you use a regular crescent blade, like how you do a SICS, get into the plane and do the dissection. So important point is, you see that I go with the crescent beyond the area of the trephination, because you need that groove for suturing and the graft to go in well in lamellar corneas, because in lamellar grafts you need to exactly position the cornea so that your astigmatism is very less. So in this an artificial anterior chamber, the same method, whatever depth you went, 200, 250, whatever, same, you make a 360 groove, and then you, with the crescent, you take the same amount of graft and you put it over the area where the cornea is, and you see how I tuck in the graft in. So this is very important, because the graft very well goes and stays, and the astigmatism is very low. So this is for superficial scars. So for any, most of the deep, if you want to do a deep anterior lamellar where you want to remove all the layers, so we use the big bubble technique, where again you mark with the crescent, and then with the side port you go around 50% depth, and then with the needle you make a small tunnel into this, so that our cannula can be inserted inside to get a big bubble. So most of the times, out of 10 patients, at least 7 or 8 get bubbles. You can see here, go inside, and then as one shot you should inject, like you should depress it down. You can see me nicely depressing it down and injecting as one shot, a bubble forms. And this is one method. And other thing is, like, there are many times you won't get a clear bubble like that. You can see that the central C3 are being done, so the central area was not dissected. You can see the bubble forming beyond, and here you can see the initial peripherally the bubble going in and the bubble forming. Again, see the periphery, the bubble goes, and if the bubble doesn't form, you can again go to another area. Same method you can do, and you can try again. You can see that going to the periphery, and then centrally you see the bubble forming. So you need a lot of patience, take care. You can see here again, here the central bubble forms. It forms, it should be one push so that it forms into a bubble. Here you can see the central thin area first forming, and then the bubble forming. So these are some of the methods which we use for separation, because manual, if this fails, you can always go like a manual dissection, keep on dissecting manually. Complications are, you can, when even the final portion of release, you can get a damage, and this is a type 2 bubble. So all these things what you saw, type 1 bubble, type 2 bubble means even the Duas layer is dissected, and you can see that it's like very thin, shiny. There are no, you can see that decimates how shiny it is. Anytime this will perforate, and just wanted to show you that even a small nick, it perforates. So all these complications can occur in DALK, and even sometimes in your learning phase when you're trephining, you have to be very careful. Just you should trephine just to mark, and you can see here, if you go deeper, it will perforate. It was not the partial blade, it was the initial trephining which caused. And here you can see that initial dissection, when you're entering with the side port, you can feel like when you're doing with the crescent, very thin cornea, even bubble will not form in these cases. But when you want to remove the anterior stroma, sometimes you can get into a perforation like this. All these things can happen, so you should have a backup tissue. So here again, when you are going with a needle, it is so thin, sometimes you can even sometimes perforate it. When you are going, you have to be very careful. You can see the saline coming out. So all these are little bit tricky. So if suppose it happens, you can go to the next side here, again do the tunnel carefully, and you can go with a bubble. So it is a matter of, you have to be very, very gentle and very careful. And even after 45 minutes of entire dissection, you have to be careful that at any time perforation can occur. So when do we really need? Because there are now so many procedures nowadays. DALK has become very less now. In my practice, in a month, when I was doing 10, at least 7, 8 DALKs, now it has come to 1 or 2, because we do so many other procedures which have now taken over DALK. So what are the factors which helps us to make the final decision, and how to reduce the intraoperative any technique to reduce astigmatism, what to expect in post-op refraction, what are the post-DALK refractive solutions. So when do we need a DALK? When you see like this 2 by 60 minus 9 minus 4 K reading around 65, 70, all these patients do not improve with whatever technique you do. And you can see here the pachymetry is less than 300, 400, contact lens fitting is not there, then obviously you have to go for a DALK. So intraoperative technique, what I generally use is a different type of suturing, as well as you see here, I do a peripheral trimming of the cornea. This is a basic logic, because the cornea where you are going to suture is 300, 400, and your donor is 600, 700 microns. So the peripheral cornea, if you trim, it gets a very good apposition, and you can actually you can get a very good apposition in this, and the astigmatism is less. And also suturing, I usually form a technique here where I do not lock it. You see here, I just make it exactly into that position, and then I usually lock it and bring it over to the donor, to the recipient side. So this I have been practicing for quite some time, and you can see that it goes along the curve. I'll show you one more time. See, when you suture, do not lock. When you lock, the astigmatism will be very high. So what I do, I tighten it according to the apposition. Once it is opposed, I know it is opposed, then I go like this, and I go tighten it and go along the curve, so that the astigmatism is less. So usually I make it little bit flat. My aim is, when the patient post-operatively, immediately if I'm able to see well, I'm unhappy. The patient should say, I'm not seeing well. And you can see here, after suturing, we can use a intra-operative cone. You can see that it's round. If most of the time you can see that the central, it's like an intrascope, you can see that it's round most of the times. So what to expect? So most of the times I expect like this, +5, +6, because the cornea is flat. From 60, 70, I wanted to go to 39, 40. Because over a period of my experience, what I've seen the last 15 years, I've seen you give 44, 45K, patient is 6'9", 6'12", first immediate 3 months. At 6 years, 7 years, 8 years, they go again keratoconic and becomes minus. So I keep them in plus, I make them hyperopic. And you can see here that this is 10 days post-op, where I around see it's around +5. It is coming to +1.7. And at 2 months, sometimes you see the astigmatism changes, and the vision is 660 +3 -6. All this turmoil goes over a period of 2 months, and you see 5 months again +4. 7 months it's around +1. You see the vision regaining 624. Still it's +0.52. And 1 year you see it patient improves 6.9, and it's come +1 and -3. And you can see the cornea is fairly okay by the time most of the sutures are out. This was what I usually prefer. In other case, you see plus at 1 month at +3.25, and it becomes at 660, patient is not happy, and you see that it becomes +0.5, 0 over a period of 8 months. 11 months, again it stays around +0.25, same range, 624, 69. 1 year, 0, and at 2 years it becomes nearly 1.75 minus. So this, and again the patient 612 and 1.2569. So this, over a period of time, I've seen this patient going here and there. So on this, I make patient around 30s and 40s flat, and over a period of 2, 3, because most of them when we operate, they are 16, 17, 18, 20. They obviously, you are suturing it to a keratoconic cornea. You are not suturing to a regular cornea. So there is a disparity. So you have to make sure that your sutures, everything is Finally, you can see that at 2 years, the patient will minus 1.25, minus 1. They remain stable over a period of after 2 years. Till then, the refraction is very unpredictable, depends on your suture and your healing. So the 10 commandments is choose when to decide on DALK, plan the right technique, whether you want to inject a bubble, you want to manually dissect, try to achieve the big bubble most of the times. Keep the donor edge and the depth uniform as I showed you. Try to flatten the cornea. Monitor the IOP, very, very important. Don't remove the suture till 1 year and keratoconus until you see a fine scar. But if the astigmatism is high, then by around 8 months, 9 months, you have to remove. Keep the patient on mild steroids till you remove the suture. And one more thing, I have seen rejections in these patients. So always keep in mind, epithelial and stromal rejections do occur, particularly when you do for young patients, post-VKC patients who are immunologically very active. Those guys definitely need monitoring and rejection can happen. Thank you.
So Sidharthan, how do you prevent the potential space between the graft and the host from developing? How do you make sure that it remains adherent immediately post-op?
Post-op, that is most of the times when you don't have a perforation, most of the times it sticks on very well. And that too with type 1 bubble, there is always an irregularity on the decimet. So most of the times we don't see, if you don't have a perforation, 90% of the times you're talking about the attachment of the, most of the times is attached from now. And that's what I make it flat. So when it's very flat, most of the time I make it almost concave. When you see
put venting incisions?
No, I don't do any venting incision. So if there is any perforation, then I do a small PI and put air into the anterior chamber. So that is better because urate zavalia, all these things quite happen in these young patients. So when there is a perforation, I usually do a small PI and put air into these.
Is there any special type of cannula you use for the big bubble?
The same that Rajesh Fogla's cannula, which is available, that's what we use.
Thank you very much. So now we go on to the next.
So exactly an opposite surgery to DALK. So I just wanted to share my experience in DMEK. So in 2013, way beyond when I think Dr. Rajesh Fogla and even Samar Basak sir did not even start these surgeries. Me and Dr. JK, we started in 2013, but we stopped in 2014 because out of 10 cases, 9 cases failed. And then after a year or two, we had to do a little bit of studying what happened, and then only we could do. And in 2020, we published along with Dr. Samar Basak the first 120 cases we published. So basically, it's the transplantation of the decimets along with the endothelium, which led to the decision on doing a DMEK. So in DSAC, there is a layer of stroma along with the decimets, whereas in DMEK, it's purely the endothelium, the decimets with the endothelium. So problem is there's a steep learning curve in DMEK because when you do a DM stripping, there are very strong hemidecimosomal attachments of the DM into the stroma. So when you are doing it, there can happen this piecemeal tear, there can happen all these tears, all these can happen. And initially, this is 2013 when you didn't know how to even inject it into the anterior chamber. And doing all these things, there is a loss of cells. And you see here, there is no mark in the endothelium. We did not know how to unfold it, which side is endothelium, which side is the decimets. We didn't know all these things. Even sizing the decimets, we did not know. We thought whether to do a small graft or we should do a large graft. Nothing we knew, and all these things usually used to happen, and even we used to lose grafts. And this is the nightmare for most of the corneal surgeons. That's why out of 10 endothelial keratoplasty, endothelial corneal surgeons, 8 of them do DSAC because they're very comfortable, the results are good, and they don't want to take any chances in this. So basically for the postgraduates, why DMEK? It's not tough, it's just that understanding the anatomy, because the decimets always folds on itself and endothelium is exposed out. So when you handle, it's not like DSAC, when you do a taco, the endothelium is inside. This endothelium is completely out. I'll show you clinically when I'm putting it as a taco. When you put a decimets into a taco like this and you put it into a saline bath, okay, you can see now the endothelium is inside. It is such a way that you see it snaps out, and the endothelium is exposed out. So this is the critical problem in the DMEK tissue, because the endothelium is out and it's exposed and there is so much of loss of tissue. So the first step what we did was marking. You do an L, you do an F, do S, do whatever you want, but you need a stamp on the decimal side. So here it's very simple. I've been doing L for so many years, means there's a short horizontal limb and a long vertical limb. So I make sure, orient myself that when it goes inside, anywhere in the eye, the small short horizontal limb is always on the right side of the longer limb. So whenever you see, you orient yourself to that side and make sure that the limb is to the horizontal, towards the right side. Sizing is very important. These are initial cases when you see that almost 6 mm, the pupil is almost 4 to 5 mm, and I have taken a 7 mm small graft. It's going to be very difficult to unfold this because it is going to stick on the endothelium, and iris is not going to help us. So iris is the key factor for doing a DMEK, and here you see even a 7 mm, 6 mm pupil you can unfold, because you see that I have taken the graft almost 8.5 mm and the iris acts as a fulcrum. You see at both the edges the iris is holding us so that we are able to unfold. So sizing of the graft is very, very important in a DM scroll, particularly during your when you start doing these surgeries. DM stripping, whether you DSAC or something, basically respect the cornea. Do not touch the endothelium. Do not touch the stroma. See, when I'm stripping, before there used to be in DSAC, you have to make some irregularity. Not in DMEK. See, you see here, I am not damaging the stroma. Don't touch the stroma. Wherever you touch the stroma, there will be a mark in the cornea. See, very carefully remove the endothelium. Do not touch the stroma. If you touch the post-operative, there will be marks of scarring there. So you have to remove a total end piece and wash out the visco. And I do not use any costly injector till date. For the last 10 to 12 years we've been using this. Don't go for costly injector. This is just a 1 cc syringe, and this is a regular phaco tubing and a C cartridge. I regularly prepare this. I sometimes prepare and keep it. We do an ETO and give. This is a regular IOL tub. I don't use any costly instrument. There are instruments available for 1,000 rupees. Don't buy all these things. It's very simple. If you know the anatomy, how to use it, this is very simple. So tissue preparation is very key. Here, after a marking with the trephine, you see that I use a Sinski. Do not lift the Sinski up. Just keep rotating. Otherwise, you will have tags. Just keep rotating it and make sure that your every edge is removed without a tag. This is all very important because we have to have a lot of patience in removing this. And once you start having a proper technique, everything will fall in place. See, I'm just removing it. Make sure, look at the edges. Make sure that they are slowly removed. You can encore remove it, or you can partially remove it. And then I make a 3 mm opening, a window in the stroma, bare stroma, because endothelium is not, I have pushed it to one side, and I stain the endothelium. Wash the endothelium. Do not touch with any instrument. It's saline, and the 2 drops. Don't put it in pores. And then you mark the with a marker, and then you put it back, and you can punch. See, whatever size you have measured in the patient, you can always punch it. And sometimes in COVID times, I will not go full thickness. I'll just mark it, and the other portion I used for dalk. So this again in water bath you can remove. So even the central 3 mm hole I do not make. I just mark it directly on the endothelium, and then you can take it in the injector. So in the recipient, remove the epithelium. Sometimes an epithelium is an indicator how much of endothelium is lost. So this area there is no endothelium. I usually decenter the graft, means that this area where the epithelium you're difficult to strip, the endothelium is definitely good there. So whenever you get a loose epithelium, it happens. So you can put, initially I used to put 2 side ports, but you can do 1 side port. You can do it with the keratome, regular our phaco incision, and then another side port for the PI. Use pilocarpine, constrict the pupil. As I told, pupil is our best friend here. And then even a PI, do a slit PI. Don't make it very big. It should not be round. It should be a little bit slit like small. Otherwise, your graft will go and get stuck there. So all these are very important critical steps which should be followed. And here the same I showed you removing the endothelium out. Sometimes you have to be very careful. Sometimes the punch may not go in. You might use the punch twice or thrice. Go to that area and release it. See, all these things, the tear can happen anytime. It is not that it can happen only when you strip, when you punch, when you take it in the syringe. Anytime it can happen. And go inside and inject it. Be very gentle about it. And the important point here is suture. You can see that the L mark is seen, it is in the right place, but still first put a suture. Do not manipulate without a suture because it will come out. And once you are done, when you know that it's there, gentle taps, usually it opens. You can see that L mark and then go inside and put a bubble. It's 19 to 20 minutes, the surgery is over. When you are able to do like this, the results are good. So nowadays, in fact, in 2020, we published this where it's a hold and release technique where I do not tap violently. You see, with the left hand, I hold the graft and I open up the graft. I inject saline and I open. It means that by gravity, when the water comes out of the tunnel, you can see that the graft opens. Because this is an SACS tunnel, I didn't put a suture, but you see that I inject saline, see it comes out. By gravity, you inject saline and you shallow it. As the water comes out through the tunnel, the graft unfolds. And just gentle tapping, very fun, no violent tapping. The thing in these cases are, again, when it is unfolded, make it mostly horizontal. Try to make it horizontal. Shallow the anterior chamber. As you shallow, it will open up. See, inject saline, you make open. See, again, I'm shallowing it. So all these violent tap days are all gone. You can see the left hand. I'm just trying to push it and make sure that it doesn't come and get caught into the tunnel. So I'm pushing it in. I am pushing it to one side. I'm shallowing it. I'm making horizontal. Again, pushing it into whichever position you want, very gently. Tap it into whatever position you want. Hold it that side and then inject saline. Open it, try to open it. Yeah, inject saline, tap it. Yeah, it opens. So you don't need to manipulate it too much. Sometimes what happens is when we try to do it, sometimes it doesn't open. And there are cases when it takes some time. When you have younger tissue, sometimes it happens like that. So here I'll just show you just a last video where you can see that I'm trying to open up, but the one near the suture, it is not opening. Whatever I am doing, it is not opening. So here, like DSEC, we cannot go with the Sinski, unfold it, tap it, nothing you can do. So what I'm trying 2 or 3 times, when such a thing happens, what we can do is we can always inject air into the center and the air will unfold it. So what I'm doing here is just holding with the left hand and trying to inject air, because otherwise the graft will get dislodged because it's very fine. So I'm putting air. So I'm putting air and I'm just releasing it, and then I will release the air beyond the edge. You can see that I'm releasing the air and the air will do the work. See, the air will do the work and it is unfolded. Near the suture, you can see it is unfolded. You don't need to go and keep on tapping. The air will unfold. So these are some post-op pictures where you can see the second day the post-op is very good and you can see the count improving. Even now, regrafts, I don't do regrafts, we do DMEK. The count remains. Even DMEK in ICE syndromes, I think PKP, when you do PKP 360 PAS forms, indication for ICE DMEK is the strongest indication. Even in in glaucoma patient shunts, post DMEK, even vacuolated, suppose the IOL is not there, you do an iris claw, remove the IOL, even failed TKPs, hemicentric grafts. Now we have pushed even one side endothelium is good, we push it, hemigrafts we do. Even these grafts, you can see that vascularized, scarred. See at 1 year how the cornea is. Because doing a regraft in these patients, 100% it's going to fail. So choose what is comfortable, repeatable and successful in your hands. So 10 commandments is inclination to take up the challenge. DMEK is challenging. There is a definite learning curve compared to DSEC. Know the DM orientation, orient yourself, case selection, pupil should be there, iris should be good, stripping, take patience in stripping the tissue, mark the donor tissue, apply a suture, unfolding, be gentle, don't be very violent, reconstruct the pupil. If pupil is dilated, do a pupilloplasty, place IL, good vitrectomy, and most important is have a backup tissue when you start. Thank you.
Thank you, Siddharth. So I usually start with a high cell count in DMEK. So what's your minimum that you would take?
Yeah, so above 3000 and above 40 years of age. So nothing less than 40. I don't go above 60 also because what I feel is the endothelial cell loss is more in these patients because additions are less. It's easy to unfold at 60, but the amount of endothelial cells falling when you tap is higher. So I keep around 40 to 55 age and count above 3000.
Could you please tell the audience why not below 40?
Yeah, because the endothelial is so, what to say, as I told you, it scrolls on itself. The endothelial, the hemidesmus are very tough. The collagen is more stronger. So generally we take above 40. So that's why they say in PDAC or in any other DSEC we can take young tissues. But in DMAC it is only above 40 because the scroll, it's very difficult to unfold. It becomes like a very difficult scroll.
And it also depends on systemic conditions like diabetes and a few. Thank you so much. Very enlightening and very accurate.